Hi, everyone. I'm Heather Gotham. It's nice to be here. I think this is my fourth time presenting to you all over the years, and I'm really thankful to Brian and NASMHPD for allowing us to do this. We at the MHTTC network really see ourselves as your partner. You are our key stakeholders in the work that we do, and I wanted to talk today a little bit. We're going to slide away from crisis services for a moment and talk about training and technical assistance. And I wanted to talk about ways in which we hope to be even better partners to you in the future. So disclaimer, very thankful to have funding from SAMHSA for the work that we do. Just a bit about our values at the MHTTC network. We try to use affirming, respectful, recovery-oriented language in all our activities. So roadmap for my talk, again, I think our amazing previous speakers have all been talking about services and crisis. And we're going to switch the conversation a little bit right now and talk about training and technical assistance. There are a bunch, to use a technical term, of training and TA centers, especially funded by SAMHSA, that have come out in the past few years that are available and able to provide training and technical assistance to all of you in your states and regions, territories, tribes. And I want to talk about how we do that, how we provide training in TA, and how we can do that to be more impactful in the services that you're offering. So we know that there are these critical gaps between implementing effective interventions and the services that are provided. And Deborah spoke to that this morning about saying we need to increase the access to evidence-based practices in community settings. Crisis services is a huge place right now where we now need to make sure that the services that we're growing are evidence-based. Unfortunately, many technical assistance and training opportunities really rely on one-time, we're going to do a webinar. Oh, you need help? We're going to do a webinar on that, or we're going to provide a one-time training. And I want to talk about how we can use dissemination and implementation science strategies to make sure that the services we're providing to you aren't just a one-time thing where your folks are going to come to it and then that's all you get. How can we really do that better? And illustrate that using 4 intensive TA projects that our centers have done. And then at the end, I'll just preview some of our upcoming work. We're just about to start year 5 of our 5-year cycle. How many folks are connected with your regional MHTTC? Yes, some, okay. All right. So if you don't know about us, please jump on our website, mhtttcnetwork.org, and check out our work. We are Mental Health Technology Transfer Center Network, so don't focus too much on the technology in our name. Technology transfer, when the ATTCs, the addiction TTCs, were started 30 years ago, technology transfer meant implementation of evidence-based practice. It means a little bit something different now, but locate yourself on the map and find your regional center. We are a network made up of 10 regional centers that cover all the states and territories. We have 2 national focus area centers, one covering Hispanic and Latino services and one covering American, Indian, and Alaska Native services. And I'm with our network coordinating office out of Stanford. So how we work a little bit different than some of the other TA centers you're going to hear about over the next few days, because some of my compatriots will be here speaking with you. We're regionally based. Most of the work that we do is out of those regional centers, and that is awesome because we get to provide really tailored resources to all of you. We work really closely with all of you, with our SAMHSA regional administrators, and with other local stakeholders to understand what are the needs in your region and your state, and we develop annual work plans. So we're less about responding to specific TA requests. We don't usually work with SAMHSA grantees, although that's a little bit different with our school mental health services I'll talk about in a minute. But again, we're there kind of on the ground to try and provide services that are going to help you. And I'm going to talk about this D&I science thing. So if you're not familiar with it, dissemination and implementation science is the scientific study of basically how you get folks to change and how we can better implement evidence-based practices into your settings. There has been really a rise in D&I science over the past 30 years or so, so it's still a relatively new science, but really important, again, when we're talking about systems change. Not the same as improvement science, but kind of in a similar vein. So I want to talk about 3 specific frameworks in D&I science that really could help impact the training and TA that you're receiving and that you should be thinking about as purchasers at times, or even that you're, like, our services are free. But 3 specific frameworks that can help make sure that the TA that you're getting is going to count. One is the focus on implementation stages. So anytime you implement a new practice or any kind of change, you know there are steps and stages that have to happen. And within D&I science, there's a few different stages. I want to do a shout out to Dean Fixon and Karen Blasey and their colleagues at NERN. Thank you, David Schern, who really had one of the first stages models. More recently, Greg Ahrens and colleagues have developed what's called EPIS. Okay. So EPIS stands for Exploration, Preparation, Implementation, and Sustainment. And again, you're thinking about, if you think about a change process that your agency has been through or one that you've been part of, there's different stages. There's an exploration stage where you're trying to figure out, do we need a new practice? Is there a problem with the services that we're providing? How do we explore what some evidence-based practices might be to fit the need? Then a next stage is preparation. That's where the training comes in, right? You're training your staff. You're gaining internal and external support for this change. Then there's implementation, where you actually start using the practice. That can be really hard. No one's happy in that early implementation stage. It's like, I call it being like a gawky adolescent, right? You're just starting a new practice. The patients hate it. The consumers don't like it because you're not fully operational. All the staff are upset. It's awful. There's like hormones raging. It's really difficult. But when you get through that into the full implementation stage and you're able to see, like, hey, we can do this new thing, it feels a lot better. So implementation. And then sustainment. Once the program's embedded, right, that doesn't mean you just get to, like, pat yourselves on the back and be done. That means you need to figure out, what is it going to take to sustain and keep this practice rolling over time. So it's really important, I think, to set expectations in a service system with providers, with folks at all levels. Really important to understand these stages so that you can set expectations for how this change process is going to work. A second thing to be really mindful of is the context. So implementation cannot be separated from context. There are barriers and facilitators in each setting, in each clinic, in each service system that really can impact how well this change process works. So there's, again, a number of different models for this in implementation science. If you've heard of CFR, Consolidated Framework for Implementation Research, that's one big model. I like to just streamline it down to these three levels. You can think about barriers and facilitators at a systems level, things like state laws, Medicaid rules, systems, big picture stuff. You can think about barriers and facilitators at an organization level, so policies and procedures. Is there leadership, engagement, and buy-in for the process? And you can think about barriers at the individual level, so your workforce level. How do the staff feel about making a change? What are their attitudes about the new evidence-based practice? Do they buy into it at that level? What are their skills? So barriers and facilitators. And then the third one, third D&I science framework to think about are implementation strategies, which are, in my speak, are the TA activities. So if you have a TA provider coming in who's going to be helping you, they're trying to figure out, do we need to do training? Do we need to do some kind of longitudinal technical assistance? What's it going to take? So those activities, those TA activities or actions, those are our interventions, and they're going to help you figure out, those are going to help you to implement the practice. And the important piece here is about how do we as a TA provider, how do we choose which strategies we think are going to help you? And so there's a couple ways to decide which implementation strategies, which TA activities might be helpful. In the TTC networks, We look at a 3-level model for training and technical assistance, right? So let me just walk you through that quick. Basic TA includes things like mailings, treatment manuals, conference sessions, short seminars, webinars, basic TA. The goal of those are really awareness raising and training, right? Awareness raising and dissemination. So we know that webinars don't do a whole lot, right? They raise awareness, they educate. That's really all that they do. So we want to make sure, again, we're managing expectations about how much change can you get out of a webinar. And the impact of those strategies is really limited. So there's a lot of research that shows that those kinds of passive approaches don't result in behavior change. We wouldn't really expect them to, although sometimes we do expect them to. We hope that they do. So targeted training in TA can help support skill development. So targeted training and technical assistance are like one-time trainings, workshops, things where you're having people practice what the skills are. And so the gains from those tend to be pretty short term. We call this train and hope. Or one of my colleagues said, we pretend to train you and you pretend to change. So targeted training in TA. Again, there's places and these are all important pieces, but let's be really honest about like what's going to change from a one-day workshop. You send your folks to a workshop, you don't expect they're going to come home and suddenly be different people, right? That's not how it works. So what the real secret sauce to training in TA is this intensive TA. And those are things like ongoing customized consultation. Like this is where the hard work is, right? Because change is hard. Ongoing coaching and consultation, performance feedback where you have your folks submit an audio recording of themselves doing a motivational interviewing session and we give you feedback and they learn. Project Echo is a great model for that. Learning collaboratives that Denise was just talking about, right? Those are really intensive. They take a lot of effort, but that's where you really get the change. That's where you really get the change. So this is my favorite example. It's old, but whatever. My favorite example of this is this was by Joyce and Showers, and they're looking at new education practices in the classroom and whether or not you get different kinds of outcomes. It's a pretty depressing slide, but it's very informative. So if you have a training and all you do is talk about theory and discussion, which is kind of what I'm doing now, which is part of what's depressing, but anyway, 10% of you will walk out with new knowledge, 5% might walk out with some kind of new skill. Do people use it in the classroom? No. If the training includes demonstration, there's not much change. If the training also includes all those things plus practice and feedback during the training, so role plays, there's a little bit of change, that's something, but do people use it in the classroom? No, they don't use it in the classroom because the only way to get people to really change and use something in the classroom is to demonstrate it in the classroom. So again, as you're thinking about being purchasers of TA or expending the effort to take in the TA and the training, these are the things to be thinking about. How can we provide intensive services in ways that that your systems are going to be able to accept? So in the MHTTC network, we really try to live by these D&I science principles. It's been so hard during COVID, right? Like we were ramping up this, okay, great, we're going to be doing this intensive TA, and then COVID hit, and people couldn't even sit through a webinar, right? Like people said, can we have 15 minutes? Can you just tell us something we need to know in 15 minutes? Because that's where people were, right? And we did that. We did tons of webinars on those like key clinical things that people needed. How to do telehealth, how to do suicide care in telehealth. We really tried to shift and focus on the things that you need because we serve you. But now we're hoping to slide back into that more intensive TA. And so we're trying to use these 3 D&I strategies in this, so that when we are asked to do a project or when we're considering a project with a state or a region, that we're thinking about what stage is this project at? Because lots of times we find people jump right into preparation where maybe they need to go back to exploration and understand, like, why do you want to implement an evidence-based practice? Like, what's going on with your client base? Do you have data to show that something's not working? Then let's explore what might be a good thing to do. To really understand the context through doing some early assessments, to understand what are the barriers, what are the facilitators, and then based on all of that, to design those precision implementation strategies. What's going to help? You might not need training. Maybe you need something else, and let's work on that together. We recently published an article in General Hospital Psychiatry where we talked about all this and then had our centers talk about 4 intensive TA projects. So I want to highlight those briefly now. Northeastern Caribbean, shout out to our Northeastern Caribbean folks, New York, New Jersey, Puerto Rico, US Virgin Islands, woohoo. So they wanted some help with implementing motivational interviewing. That's a typical request we get. They worked with 4 behavioral health organizations, and before they even started, they asked for and did some assessments on barriers and facilitators. There was a really high level of interest. People were committed. They wanted to do motivational interviewing. That's all awesome. This project started, and like 2 months later, COVID happened, the pandemic hits, and all the centers go into crisis mode, right? And the staff start turning over and, bad things start happening. So one of the great things about MHTTCs is we're nimble. And so they were able to really change up the project in the middle to best fit the needs of the organization at that time. They provided in the beginning different bits of education to all the staff in these behavioral health organizations, right? So they're not just training the clinicians, they're training everyone, but providing the level of information that you need, right? Not everyone on the staff needs full motivational interviewing training, but they might need to know about it. They did group coaching, they did fidelity reviews, and then they provided a training of trainers in order to build that local capacity to keep doing motivational interviewing, because the last thing you want is to implement an evidence-based practice, then your staff turnover, and then you need to get trained again, right? So how can we build in that local expertise? They found improved MI skills, high training satisfaction. One of the things that I thought was really interesting was lots of staff talked about how helpful it was to have a common language for motivation and change in the consumers, how helpful it was to have that across the agency. And as much as I am like so focused on like, let's change outcomes, let's change clinical practice, whatever, like sometimes I think that the juice is really in the attitude change that you get from a really good in-depth training or TA experience. And that's what I see this common language across the agency piece is we really got people thinking about how they interact with each other and how they interact with their consumers. The Northwest MHTTC, shout out to, I'm not gonna name all the states because I would get lost in the middle, but Alaska, Washington, Idaho, Oregon, okay, you know who you are. They were interested in implementing cognitive behavioral therapy for psychosis. So the Northwest MHTTC worked with 9 coordinated specialty care programs and within one state. They were part of a network, so they also worked with that network clinical training director who was the huge champion in this case, which was really important. They did some early assessments. They had an organizational readiness tool and found there was, again, high clinician and stakeholder interest, high motivation. But when they got down into it, they found that a lot of the folks who were part of this process had multiple roles. So some of them were clinicians, but some of them had these other administrative pieces that they needed to do. And so it could be hard to find time to get the training, time to turn in tapes, time to do all these pieces. Again, the implementation strategies were molded and shaped for their specific, for the specific project. So they did a multi-day in-person CBT workshop, again, consultation calls, fidelity reviews, and a training of trainers with that network clinical training director to really, again, build that local capacity. And they found improved CBT knowledge and skills, and again, that secret sauce juice part I talked about, gravy maybe I should call it, improved attitudes towards psychosis, toward people with psychosis, even in folks who are already working, obviously, with folks with psychosis. So those are two EBP-specific models, but we can also use D&I science in the other work that MHTTCs do, which includes supporting organizational change. So here's an example from Great Lakes MHTTC, where they were looking at reducing no-shows in virtual appointments. So this is right after the pandemic started. Everyone switched to virtual, and at the beginning, patients were always showing up, no problem, and then they started finding a lot of no-shows, and it was kind of sliding downhill. They were really worried about that. So Great Lakes MHTTC came in pretty quickly and developed this training in TA to address that. So they worked with 11 behavioral health clinics. Through their assessment of facilitators and barriers, again, high clinician stakeholder, interest, motivation, this is all great. Patients were demanding virtual services, that's awesome. Some of the barriers, though, that were important for them to address included patients' access to technology, keeping leadership and staff aligned on the project aim and not having it trickle off into other things. We have that kind of mission creep, which just happens in a project. And then really focusing on system changes. This was a learning collaborative. We've done some work in the MHTTCs on what makes an effective learning collaborative, and we have a white paper on that, which is available on the website. This is an example of a really high fidelity learning collaborative where they did sharing sessions with the behavioral health clinic staff. Those staff submitted data 3 times throughout this project to really be able to track that actual change was happening in practices. And they used the rapid cycle plan, do, study, act process. So they found decreased no-show rates. One of the pieces that was an innovation that several of the centers did that really boosted their or decreased their no-show rates was the use of text reminders, which sounds pretty simple now, but 2 years ago it was like a new thing for them. And then really moving toward patient choice in terms of whether patients wanted to receive in-person or virtual services when that became available. All right, my last example is, again, a little bit different. This is advancing systems change. This was a regional school mental health learning community from our Southeast MHTTC. Again, shout out to all the amazing states in the Southeast. This learning community included 6 state teams, so this is really cool. We got the behavioral health and the education leaders in 6 of these states together, and they formed a team that included 6 to 12 members. This project happened right, or I should say soon after the Parkland, Florida school shooting, when many of these states put a real emphasis on school mental health services, which has really continued now through the pandemic. So with that, again, there was great desire and urgency at the state level to implement school-based mental health services, which was awesome. And then the pandemic, of course, happened, and so then the shift, we had a little bit of a shift in terms of the focus, but we persevered. This was also a learning community. So learning communities are similar to learning collaboratives, not quite as rigorous in their methods. This had 9 learning sessions. They had the folks develop SMART goals, so being really goal-focused. Our 6 state teams. They did coaching calls with the state teams. They did state-specific training. So again, you're seeing this theme of really intensive and individualized TA services. And they found that 5 of the state teams reported progress on their goals. 3 teams achieved at least 1 goal. 1 team achieved all of them. So kind of to summarize, this is a lot of work. We know this is a lot of work. Your state systems and the agencies within your state who really go after implementing evidence-based practices, we know this is really hard. And that it's important to have a really good match between what your system is interested in and able to bear and what the TA provider provides. I also really love these examples because I think they really show the benefit of this state and regional focus that our MHTTC network is able to provide, because that's how we work. And then trying to, again, show these D&I science factors. So readiness assessments are really important. When a TA provider comes in, they should be asking a whole bunch of questions before they figure out what kinds of TA they're going to actually provide. Training is necessary but not sufficient. And how important it is to adjust the intensity and the content of the training and TA based on what happens in the universe, like a global pandemic. Wrapping that up, looking forward to our year 5. It's hard to believe, yes, we were funded 4 years ago. We're on a 5-year cycle. We're hopeful that SAMHSA will refund and rebid the MHTTC networks, as well as our 2 sister networks, the Addiction Technology Transfer Centers and the Substance Use Prevention, PTTCs. In 2021, we did a needs assessment across our 10 regional centers and found we had about 2,300 folks participate, and this was across behavioral health providers, some school mental health providers, state-level folks. And I wanted to show this. I think it's important and maybe not surprising, but I think reifies some of what we know in terms of what the top technical assistance needs were identified through this. That first one is equitable, culturally responsive services. So you can see almost twice as many people identified that was a training need compared to the next set of training needs. And we are committed, all the TTCs are committed to providing training and TA on equitable, culturally responsive services through our national focus area centers I mentioned, Hispanic and Latino and American Indian and Alaska Native, but also across all of our regional centers, even as a number of our centers are reporting starting to have some difficulty providing these training and TA services in some states based on current political climates. So that I found interesting. Number 2, training in need was co-occurring mental health and substance use disorders, which I found interesting because I don't hear a whole lot about that as recently. And I got my start 20 years ago-ish in this field working in co-occurring disorders. So it's not gone away. It's still an issue, and it's still something we need to pay attention to. And then we see mental health awareness and promotion, trauma services, and then crisis services was number 5. So I show you these in part because these are the things that our MHTTCs are focused on and should be focused on in this coming year. We also were excited to provide these results to SAMHSA to hope that they might think about developing or increasing funding around some of these services or some of these training needs and topics, develop services grant programs. So the extent that you can help us elevate these, I hope that you see that they fit with what's going on in your region, or let us know if they're not. And you can get the full report on our website. We're very thankful this year to be provided another year of school mental health funding. So in addition to our main funding, which is across all of mental health prevention, treatment, and recovery supports, we're also funded specifically for the School Mental Health Initiative. It was looking a bit sketchy a couple months ago, but we're excited that SAMHSA was able to find funding for us, again, for our year 5, which starts in about 3 weeks. We're going to continue to provide training and TA on implementing comprehensive school mental health services, including to Project Aware grantees. So another shout out, if your state has a Project Aware grantee, we will be partnering with you and can partner with you in that work. We're also providing training and TA across a whole bunch of specific topics in school mental health. And then goal 3 is new for this year for us. We'll be working to across our network to implement a coordinated and integrated approach to training and TA on school violence. And then our specific request to the network coordinating office that I represent is to do a white paper on the use of behavioral threat assessment teams. We're going to be working in the next few months with the National Center for School Mental Health to do some listening sessions on behavioral threat assessment teams and hope to put that white paper together and have that out in the spring. A couple specific shout outs on our work. I wanted to remind folks that we have through our school mental health initiative, developed it's called Classroom Wise. It's a 3-part training package for educators and school personnel on mental health literacy. It's available at classroomwise.org, and it includes an online course, a 5-hour online course, video library and resource collection that are housed on our website. The video library is really awesome. It's teachers and students talking about mental health. They're really brief, like 30-second to 1-minute, 2-minute videos, talking about mental health, talking about strategies that teachers can use in the classroom to support student mental health. We've had 10,000 folks just in the first year complete the online course, and several states have incorporated this into their required professional development. So again, we're hoping to elevate the ability of educators and school personnel to be mindful about school mental health issues, and that's going to help build partnerships with all of the work that you do. Just last week, our Central East MHTTC launched a companion course to Classroom Wise on cultural inclusiveness and equity, really trying to emphasize how inequities in education impact student mental health, and things like implicit bias and how that affects our perceptions and responses, and then learn culturally inclusive classroom strategies to support student mental health. So similar to our regular Classroom Wise, CIE Wise has a video library, an online course, and resources. And last but not least, SAMHSA asked us to lead a collaboration between our network, National Institute of Mental Health, EpiNet, and PEPNet to provide information on the EpiNet's core assessment battery. So I'm forgetting EpiNet is Early Psychosis Intervention Network. Yes, EpiNet. So that's a group of, I think, over 100 clinics across the US that are funded to provide early psychosis services. And they're part of a research consortium funded by NIMH. So we have a 2-session set of webinars. The first was in May 2020. That's not right. It's May 2022. We just did this a few months ago. I don't know what I was thinking. My error. Time, it's become really fluid, hasn't it? Just a couple months ago, we did this session for providers on the core assessment battery and how that can get used in clinical interactions with clients. And our Texas EpiNet site, which is also our Southwest MHTTC, had some of their clinical folks on talking about the CAB and the web CAB, the web-based version of the CAB as they call it. So that's a great recording that's available on our website. Coming in September, soon you will be getting information. We're doing a companion to that first session. This is specifically for state staff and agency administrators, also on CAB and web CAB. And we will be asking NASMHPD to help us promote that. So stay tuned about that coming up in September. We were going to have it like 2 days from now, and we thought, I think you all are kind of busy. Let's not have it now. We'll put it in September, and we hope you all can come to that. So I urge you to please go onto the website, find your center, connect with them. I have a booth outside. There's lots of good information there as well, so come visit me. And you can always contact me, and I will get you to your regional center and national focus area center. Thank you.
Thank you, Heather. Go. Thank you, Heather. I've had the privilege of knowing Heather for a number of years. She served in our ATTC, and implementation science was new to me some years ago. And I appreciate Heather being able to really make complex science, at least in my head, very practical. And,
good, thank you. I tried.
Yeah, you do. You do an excellent job. And so we have some time for some questions.
David's got a question.
Excellent.
Oh, hey, sorry, sneak up behind you. I'm sorry.
No, I was not facing there.
I'm Dave Shuren from NASMHPD and working on the EpiNet project. So shout out to you for helping to promote that. NASMHPD's role in that is to facilitate dissemination. And so along with Steve Adelsheim at Stanford, we're trying to figure out ways that we can effectively do that. a great presentation, Heather, and I really appreciate, the background in dissemination, implementation, research, because I think we need more of that. As you laid those models out, though, it was pretty clear that to really change behavior requires relatively more intensive work than we traditionally have had funded in our systems. We're much more around awareness raising, and I think that some of the gaps that we have in terms of evidence-based practices speak to that. We're kind of at a unique time in many ways right now because of all this non-recurring funding. There was a ton of money through all the COVID implementation, and we just got a bunch more money through the gun safety bill that was sort of wrapped up in mental health treatment. What's your thought about, I guess, what have you heard and what are your thinking about how we might use some of the non-recurring resources to build kind of enduring infrastructure to address some of these continuing problems that we've had for years and years?
Yeah, thank you. Well, that's a lofty question. I think I would start with, I hope, sometimes it's not about the money. I hate to say that, but sometimes it's not about the money, right? So maybe right now, hopefully some folks are at a place where they do have the money and can focus on the what's not about the money part of. So that has to do with when you're implementing evidence-based practices, right? It has to do with using some of the strategies that I talked about to really thoughtfully plan. If we want real change in our service system, can we use that non-recurring money to build the data infrastructure to know how well are our services being utilized? What are our outcomes in our service system, so that then we can start exploring. So we're back to the beginning of those stages. We can start exploring and really thoughtfully thinking about, do we need motivational interviewing? Do we need DBT? Do we need MST? Like, what do we need? And really do a lot of that early planning, which I think often folks jump to, like, we need to do an evidence-based practice, let's do this one. So I think that's a big piece of it. Piece of it is starting with that exploration and engaging the TA partners then. Sometimes you're engaging a TA partner that's really specific to the evidence-based practice, right? You decide to do an MST, you get MST services involved, or whatever the TA partner is. But I think involving us earlier in the process, I know MHTTCs would love to be involved earlier in the process, so that we can help folks through that exploration stage. I think there's also ways to build, so I talked about data infrastructure, and again, not just the patient outcome, but also things like fidelity. So if you're talking about, I think tomorrow we're talking about supported employment, or one of the next days we're talking about supported employment, we're talking about some of the other evidence-based practices. How can we build that infrastructure so that over time we're sustaining high fidelity evidence-based practices of whatever kind they are? Those are a few thoughts anyway.
Okay, other questions?
So I agree. I don't think it's all about the money.
Not always.
But I think what my question is how do we as states figure out a way to most effectively work with the MHTTCs? How do we structure our organizations? What we do, I'm sorry, Leanne Reinert, Illinois, forgot. Sorry, Brian. We have some really great evidence-based practices that we've built in Illinois. IPS is a great example. RAP is a great example. We've got great coordinated specialty care. But each of those things has happened because there was somebody within our organization that was a champion of that, right?
Yep.
So it wasn't that it was explored and this is what we need. It was, ooh, I like that.
Mm-hmm.
So then we get experts trained. We have our core group, and then somebody retires or takes another job, and it kind of crumbles. Mm-hmm. So I don't know if you have thoughts on. In my head, we need more of like an overarching structure to support evidence-based practices. that interacts with the MHTTCs at the state level. So I don't know if you've got thoughts about how that might work.
I'm thinking about infrastructure at the state level, right? And we all find that. We find that in individual agencies as well as in state agencies. You got the champion, they know about the evidence-based practice, they push it, it's awesome, and then they leave or they retire or whatever, or they move to somewhere else, and then like you're saying, it crumbles. So is there a way to build into your state structure within the state agency expertise in evidence-based practices more broadly? And I know recently, many states experienced like huge cuts just in the last couple of years. Maybe that we have a bolus of money now, but and so you might have had to cut most of your staff, and so that person might be gone. I think there's also ways through compliance sometimes that people can build in, like fidelity reviews. Even if it's a process where you're having your programs review each other and do peer reviews, it's still something, right? I'm thinking of the Missouri example. I've spent a long time in Missouri. I'm thinking of the Missouri example of paying for clinical supervision on specific evidence-based practices is a way to help build and maintain them as well. So those are a few pieces of infrastructure that I'm thinking of. I also wanted to say there is a whole web of TA providers at SAMHSA now, again, that have either continued from previous administrations or have recently been funded. And it's really important. I should have had that slide up, but if you go to the main SAMHSA webpage, there's a tab, it's like one of the first tabs on practitioner training, and that shows you all of the TA centers. And there's a lot of us, mostly on specific topics. We're going to hear from SMI Advisor. There's one on child and family specifically. There's an eating disorders. We're going to hear from the aging folks in the next couple days. There's LGBTQ. All kinds of stuff. And so it's also thinking about how can you leverage all of those TA centers to provide training in TA that's going to fit the needs. So it might not be the MHTTCs, although we can help get you to those other national centers. But I think that's another piece to think about, is how can you leverage those services, as well as I know you all have great training and TA programs within your either state university systems or just universities within your states or regions that you're partnered with as well. So sometimes I think it's about how to be strategic with all of those partners.
Okay, Megan, I think we're up for a break. We are at break, and we'll come back in 15 minutes. And Heather, thank you again.